Bonjour. Tout d'abord, merci à Guy pour m'avoir
Thank
invité
you,
à animer
Guy,
cette table
for
ronde.
inviting me
Et
to
en
moderate this
2018,
roundtable. In
célèbre
2018,
quotidien
a
français
famous
a
French
publié une
newspaper
enquête
published an
intitulée Les
investigation
télépatients,
entitled Telepatients,
espèces en voie d'apparition.
an emerging
Les
species.
intervenants. C'est qui, dans votre expérience,
For
les
you,
télépatients?
who
Maria.
are the telepatients?
Oui.
Maria.
Ok.
Okay,
Alors,
thank you.
Le télépatient, pour moi, c'est le télépatient
For
assuré
me,
chez AXA.
telepatient is
Le
a
service de
telepatient insured with
téléconsultation a
AXA.
été lancé chez nous en
The
2015.
teleconsultation service
C'est
was launched
l'expérience que je vais
by us in
partager avec vous,
2015.
c'est tout
That's
ce
what
que
I'm
je
going to
fais.
talk to you about. That's what
Donc,
I'm
en
familiar with.
2015, on lance ce service de
In 2015, we launched the
téléconsultation générale pour les
teleconsultation
assurés,
spaces
donc
for
clients
general
des
practitioners
mutuelles. La garantie
with mutual
téléconsultation,
insurance
elle est
companies,
incluse
and
dans
the
les frais d'activité
teleconsultation
fréquentaire.
guarantee
Ça veut
is
dire que le
part of our
patient ne
standard
règle pas la
guarantees.
téléconsultation.
In other words, the patient
Et ça veut
doesn't
dire
pay
que
for
le
the
médecin ne coche pas
teleconsultation,
auprès de la
and
sécu. Donc, le service est accessible
this is
pour lui,
applicable to the physician. So this service is available to the patient, their spouse, and their
On
children.
a aussi une partie qui est individuelle. Et là,
Another part is individual. There we have older patients. Let's say the telepatient is somebody who is active,
c'est majoritairement une femme.
usually
60% de
women.
notre
60% of our
population, c'est des femmes.
population of telepatients are
Ce
women.
sont plutôt des adultes, 80%.
They are
dans
adults.
notre
80% of
échantillon.
them are adults in our sample.
20% d'enfants quand même, dont un tiers entre 0 et 3 ans.
A third of the children are aged between 0 and
La
3.
moyenne d'âge, c'est relativement
The average
jeune, c'est
age is
32
quite
ans.
young, it's 32.
Et majoritairement en région.
Most of them in the region, 56% outside Paris. It's surprising because most of our portfolio of patients is in the Greater Paris region and in the French Foreign Territories. The service is accessible via a digital platform and also by phone, because we know that not everybody has access to digital technology in France. It's an unlimited services, but our users don't make tremendous use of it on any 12-month period. A lot of people never use it at all, and the people who do use it only use it once in that 12-month period. What else can I say? When do they call? When do they ask the service to help them? Either it's because they don't have a family doctor, or their family doctor has retired, or their GP is not available within the time that the patient feels is reasonable for their issue. Thank you, Maria. I have a couple of other things to say to you, if you don't mind. The other thing is, why do the patients call us, call this service? In our experience, it's because they have minor ailments, either the respiratory tract ailments, that's usually the most frequent. Then in 2022, of course, there was COVID. That was our second reason for calling, and the third was a flu and cystitis. It was the fourth reason people were calling. There are other pathologies as well, but you can see these are relatively minor ailments which can be treated fairly easily by teleconsultation. What happens to them once after the teleconsultation? What did the GP say about the teleconsultation? In 80% of cases, teleconsultation makes it possible to solve the issue. In 22% of cases, our practitioner represents a physical meeting, and most of the recommendations are to the family doctor, or if there's no family doctor, to a GP, or very occasionally to an A&E. So finally, what do our telepatients say? They're pretty satisfied with the service. They would recommend it to a relative or a friend. In 92% of cases, they consider that 84% of the cases it provided a response. We provided a response to the issue. So that was my experience with telepatients. Bernard, what is your experience? I have quite a long-standing experience. First of all, I have a conception which is similar to Edgar Morin, an anthropological, biological, ecological and political conception of this type of medicine. Since 2008, I've carried out a certain number of missions in the regions on telemedicine and telehealthcare. For a long time, patients were a chimera. They didn't exist. There was an acceleration, of course, because of COVID, and then a sudden decrease after COVID. Everybody has seen that as well. In parallel to that, studies have been published in the US before the Omnibus Law to talking about how this could be funded during the COVID period, how they're going to finance access to treatment for Americans who don't have access to treatment. So they did a study to see who had benefited from telemedicine. It was mainly women, young people who can buy a Porsche car, 10,000 people, 10,000 people out of 330 million, and 45 million people who are out of the health system remain outside the healthcare system. We carried out a study in France. I verified this yesterday. In France, we've carried out studies, and we've realized that when people have used teleconsultation and telemedicine tools, we get more or less to this same result. In basically, the people who would like to involve the telepatient everybody talks about, who does remain a bit of a chimera, is a person who still today does still not have access to healthcare for many reasons. I've built up my experience on a territory called the Hainaut-Cambrésis. It's in the north of France. There are 3,300 people who die prematurely every year. Premature death is between 50 and 60 years old when you have a chronic disease. In that sample, you have a lot of potential telepatients, except that to be a telepatient, you also have to have access to the telehealthcare tools. I had a chance to talk to one of your compatriots, who is a medical director for a huge Chinese company in Europe, and who said to me, we've built avatars of physicians who know everything a little about the computer who beat Kasparov at chess. They know everything. They have all the decisional capacities. We put the avatars in front of the patient. They connect up to internet if they can, and then we will solve their problem of diagnosis and treatment and follow-up. So it's a bit of a dead end, really. It was what Professor Pujol was saying yesterday. How do we look at people in the eyes? How do we see what they're not telling us? So for a telepatient, it's a very complex situation. You have the feeling that when you have the tool, you're solving the problem. But as you were saying earlier very clearly, you have very few people who go to use a service which is free, well, virtually free. The access is free for them to use. And what happens? These people are usually referred to practitioners. So it's just one stage in the process. I'll talk about the political aspects a little bit later in the conclusion, but we can see that there's a sort of confusion today about this because the technology that is present and useful and can be used, I use it very often. Well, I know that it works. That's not the problem. The problem is that if it is useful, people should use it, and if it's used, what is it for? So, if in a healthcare system, because we're talking about patients who have symptoms, you don't necessarily always have symptoms, even if you're sick, or even if you have a chronic disease. So if you have a kind of permanent exclusion of a group of the population which is very large and which continues not to be able to gain access to healthcare. Perhaps there are solutions from the other people around the table. Yes, Cedric. Yes, it's true. I'm going to talk in a very concrete way in this round table. I'm a GP with my individual practice for 21 years. I'm a local guy from Annecy. I've done about 9,000 teleconsultations over the last 3 years. I'm not expecting a round of applause, but I think in any case that I can say that I have a certain credibility in the field. What I'm going to talk about are not necessarily figures and studies, but it's what I've experienced and continue to experience every day with my patients. That's what's interesting. For me, for that I'm considered to be an ugly duckling for the local health authorities, and I've become a kind of UFO for medical corporation and some of the trade unions. So what is a telepatient? A telepatient is separate treatment or management of two different categories. The first category are the unscheduled treatment. On the other hand, you have programmed scheduled teleconsultations. The scheduled teleconsultations normally take place with the family doctor. Guy Valencien talked about family doctors that I'd like to comment on later on. The second thing, of course, is all of the orphans of the general practitioners who have problems with getting access to treatment, which is a very touchy subject at the moment. So what is a telepatient? It's a telepatient who doesn't have a GP. It's often a young person who doesn't have time to go to the surgery. It's a young mother who doesn't have time to go to a waiting room to wait for 2 or 3 hours at the GP. It's a timid young man who is frightened to go and see the family doctor, who he wants to talk about sexually transmitted disease. It's a patient with mobility issues, a patient who's in a medical desert where there are no doctors, a person who is anxious because they come to the end of their treatment and their treatment isn't being renewed. In fact, it can even be foreign patients where we might be able to give them a teleconsultation in a foreign language. So in fact, it's everybody. It's me, you, it can be any of us. It's anybody who at one time or another needs medical expertise and is unable to find what they need. They have symptoms and they need to have a diagnosis. So who are these telepatients? They are somebody who is able to use the technology, as you were saying earlier, and who has access to that technology, yes. So there's a socio-economic cost, of course, associated with the idea of a telepatient. From my experience, surprisingly, I have a high proportion of masculine patients, much higher in teleconsultation than in physical consultations. So this means there's a difference in access to treatment, and there's perhaps a lever for improving prevention actions in that area. Of course, they are patients who are looking for advice, they want to have information, and they often need preventive information. From my experience, I have all types of socioeconomic category. I don't have people who have a Porsche, of course. That reassures me, of course, because that's why I'm here. I'm not there to look at, I'm here to treat very, very wealthy people. As you said, Maria, earlier, it's interesting to look at the pathologies we're treating. At the moment, it's phase one. The phase one of teleconsultation over the last 3 or 4 years is the acute phase, the simple things, cystitis, tonsillitis, STDs, colds, of course, COVID as well, of course. Now we're going to move on to phase two. We're going to have to move on to phase two with the chronic pathologies and the polypathologies, multiple pathologies. What else can I say? When you have that relationship with the patient in their home, in their cocoon, if you like, there's rather an intrusive aspect. The start of my activity many years ago now, it's almost like you're visiting them at home. In other words, you're going to go to the home, they're going to feel at ease in their home, and they're going to be very free to feel very free to talk to you, and strangely talk to you about a lot of other things that they would never talk to you about if they visited you in your surgery. Of course, in the present energy situation, there's also the ecological and energy-saving factor, the economic factor, of course. And at one time or other, when I'm there and I've seen a patient physically and I've prescribed biological analyses, what is the point when they live 20 or 30 kilometers away of them coming back to see me to my surgery on an economic and biological level for me to give them an analysis of their results? Of course, my expertise does represent an added value. What is the point for them coming to see him or him coming to see me? It's a waste of time and a waste of money, and it's ecologically negative as well. So we have to bear in mind that it's a patient experience that should guide us. We're going to link up with one of your patients, Mr. Dassonville. Good afternoon. Mr. Dassonville, hello. We had a teleconsultation. I think it was my first teleconsultation patient in 2018. I'm very proud of that, and thank you for being here with us. I have two questions to ask you. What did the teleconsultation bring you in our conversation between the physician and patient? And what is missing when you have a teleconsultation? First of all, I should explain that I had a lung cancer from which I've recovered, and so I'm very much aware of any possible symptoms. This enabled me, during the COVID period, to discover the advantages of teleconsultation, to be able to talk directly to you, without having to be in contact with people who might have transmitted the virus to me. I'd like to mention two examples which highlight the benefit of teleconsultation. The first one was that it was a teleconsultation to a change in the dose of the treatment that I was receiving, so we were able to solve the problem very easily. And the second teleconsultation was a little more difficult, where you referred me to a specialist, where on the basis of the symptoms we had talked about, it was discovered I had a hernia. So this made it possible to be referred more directly to the relevant specialist. What I expect from teleconsultation is first of all, I'm very impressed by the efficiency and of the process, and COVID has enabled me to realise the advantages of this system. And also, this is the same for people who are working from home as well. I think teleconsultation can be improved, and I'm sure it will facilitate the work of physicians and will be beneficial to patients such as myself, who are very vulnerable to, very much aware of the slightest symptoms, because I want to protect myself from any danger, and enables me to be here with you today. Thank you very much. So let's have some specific questions now. Maria, AXA was the first group, as you said, to set up a teleconsultation service. Have you seen a change in the needs of telepatients over the years? Yes. In terms of the volume, of course, because the service is better and better known, especially because of COVID. And also concerning the expectations, because today
de l'expérience que nous en avons et de plus en plus
The experience we have with palliations is that they expect the doctor to do more and more things during the teleconsultation, and sometimes they find it difficult to understand that the teleconsultation has limits. 20% of the patients, as I said to you earlier, are referred to their GP because they need to have a clinical examination. That's not. It's increasingly people don't understand why that is the case because they think that teleconsultation can solve all of their problems. But of course, it's one of the solutions, but it can only function in collaboration with traditional physical healthcare, of course. And of course, it needs to have these other actors. So that's a first observation for us, for the whole team, is the level of expectation is increasing and is changing, and people are becoming more and more demanding. The second trend over 7 years, that patients are increasingly lost, disoriented. A lot of them don't have a GP, they don't know who to talk to. A lot of patients consult many different sources of information. They go to medical centers, they go to A&E. They're very pleased when we tell them there's no need to go there. So they're a little bit lost, and that's why there's a lot of demand for advice, and that's why internally we have been thinking about this, and we've set up an additional backup service which enables patients to ask all kinds of health questions. They don't need to have any symptoms particularly, and our aim there is to educate people, to give them prevention information about the drugs and their side effects, and also to help them through the maze of the healthcare system. When they don't have a GP, they're very lost and disoriented. If they need to do an MRI, they don't know where. They're told to go and see a specialist. They don't know how to find the specialist. So our aim with this service is to put the patients back into the healthcare pathway. Bernard, we've heard about people talking about confidentiality of data. How do you evaluate the relations between the telepatient and confidentiality? This is a huge question, and this is a political part of this telepatient question. And with the changes that are taking place in society, what certainly is true that we are in Europe, and from what has been voted in March and in April by the European Union, we can see that the decisions are very much inspired by what France has proposed, particularly the CNIL, which is the data privacy agency in France. So it's important to make efforts in this area of confidentiality and to go back to the patients systematically and explain to them that they have the right to give their consent. I'm talking about data for research and for other purposes as well. The management of patient data represents a huge financial value. Today, research, for example, for pharmaceuticals is research which gives value to the medical data through what we call the real-life data. We know that to evaluate a drug or prepare a drug for the market and to prepare it with others, we can see that this data is increasingly important, and this data is provided by the patients. So the telepatient isn't necessarily somebody who's only going to have a consultation. They're also somebody who's remotely, in one way or another, is going to produce data, and these data must be managed properly. We have to have a proper governance system for the management of the data. We have to make sure the patients are protected properly, and make sure that people who use the data are also protected. The question of the telepatient is a question of solidarity for a whole society. I mentioned this earlier. It's an absolutely huge group of people who today are not able to do this. And it's also a question of responsibility. And in this responsibility, all of the telepatients are concerned. Let me go back to something that happened to me in 2011 when we were wondering how we were going to connect up the different services. We were back on the DMP.
Et donc, c'était
At the time,
une grande question.
this was a big
Et,
issue.
évidemment, quand on imagine que les patients
When we imagine the patients
passent par
write
WhatsApp,
emails, they use
envoient des
WhatsApp,
photos,
they send photos,
etc., on
etc.,
imagine
etc.
bien la
You can
manière
imagine
dont eux considèrent
how
leurs
they
données et la
consider
valeur
their data
qu'ils y apportent. Ça veut pas
and the
dire qu'ils
value
n'apportent
they
pas de
assign
valeur.
it to it. That
Ça
doesn't
veut
mean
dire
they
qu'ils
don't
ont
think it has
effectivement
any
besoin de
value,
réponses,
but they know
besoin
what they
de
do know is
conseils,
they need an answer,
de
they need
conseils,
treatment, they need
mais
advice.
de leur point de vue,
From their point of view,
leur responsabilité, elle est limitée
their
au champ
responsibility is
qu'ils
limited
possèdent,
to the
c'est-à-dire
field that
de leur
they
vie à eux et
possess,
leur façon
their
de
own
vivre,
life and
leur
their
maladie.
way of life and their disease.
À nous de comprendre ça,
It's up to
de
us
faire
to
en
understand
sorte
that
que ce soit sécurisé.
and to make sure it is completely
Effectivement.
secured and protected.
Et donc,
Yes.
Cédric, du point de vue
So,
du
Cedric,
télépatient,
from the point of view of
c'est
the
quoi, où
telepatient,
se trouve le frein à l'évolution de la
where
télémédecine?
is the barrier to the development of
Concernant le
telehealthcare?
lui-même,
Concerning the
les freins,
telepatient
que
themselves,
j'ai
the barriers
essayé de mettre en avant
I've tried
sont,
to highlight
peu nombreux.
are not very
En
numerous,
définitive,
in
il y a
fact.
bien entendu les patients qui vont rejeter
There are patients who
l'idée
will reject
d'une consultation.
the idea
bien entendu,
of
à
a
distance, où c'est un
teleconsultation.
petit peu- c'est pas palpable, c'est quelque chose
It's not something that's palpable or
trop
that you can
nouveau
touch.
pour eux,
It's
il
too
faut pas
new
aller
for
trop
them.
vite, le changement, ça fait peur,
Some
donc,
people don't like change.
et
They're
on a
frightened
des
of
patients,
change,
bien
and
entendu,
of
qui
course
ont
we have
besoin de
patients
cette
who
relation
need to have this
humaine
human
présentielle.
physical
Attention, la
relationship. You have to be careful.
téléconsultation, à l'inverse de ce qu'on pourrait
Teleconsultation,
penser,
unlike what
ramène
you
de
might think,
l'humain dans l'échange
does
entre
bring
nous,
back
parce
human
qu'on n'a
factors
pas cet
into our
examen physique.
discussions and
Donc, du coup,
conversations.
on est
We don't have that
obligé
physical
d'être à
examination, of course,
l'écoute et
so we have to
à
listen very carefully, and we have to
avec le
create
patient.
an
Donc,
empathy
il
with
faut
the patient.
surtout pas mettre,
So,
cette
above
idée
all,
de-
you mustn't
de
have this
télé,
idea
entre guillemets,
that
de distance dans cet
of it being a
échange.
remote,
C'est franchement l'inverse qui se
distant
produit.
consultation.
Ce qui
On
veut
the
dire
contrary,
que
it's
dans-
very
dans
on the contrary.
mon expérience, en tout cas, c'est comme ça
From
que je
my
le
experience, this is how I see it.
Bien entendu, le frein, ça va être l'électronisme.
Of course, another barrier
Quelque
will
chose,
be
un
electronism.
sujet bien,
This
en tout cas,
is
d'actualité à l'heure actuelle,
something that
avec
is
des
being
problèmes,
in the news very
comme vous
recently,
avez rappelé tout à l'heure,
with the
de zones
problems,
blanches
as you
aussi,
said, of
donc
white
de
areas
technicité,
of
pour pouvoir accéder
where
à-
there is
à ces
no
téléconsultations.
possibility to
Donc, ça va être les
receive
deux freins, en définitive, hein,
digital services.
le
So these
rejet
will be the two
et
barriers: rejection by people and
l'électronisme
electronism.
sur lequel, en tout cas, il faut lutter. Par contre,
That we have to
de
fight
l'autre
against.
côté, en
On the other
définitive,
hand,
les freins, ils ne sont pas du côté des patients.
the barriers
Les
aren't
freins,
really
ils sont
with
du
the
côté
patients. The barriers, above all, are the political administrative level and the cooperative
du déploiement de la télémédecine. Attention,
aspect
on parle pas que de
against the
téléconsultation,
deployment of telemedicine.
c'est la télé-
Not just talking about
expertise, c'est le
teleconsultation,
télésoin,
talking
c'est
about
tout
tele-expertise,
englobé,
telehealthcare,
d'accord. Et,
tele-treatment.
Là-dedans, il faut quand même
The whole
mettre en
gamut.
avant, je suis désolé,
And there we have
peut-être mettre un pavé
to
dans la mare,
highlight
mais,
one thing. I
il y a
apologize
quand
if this
même
is a
des
bit
décisions
controversial,
qui ont
but
été
there are
prises
decisions that
l'année
have been
dernière, où
made
il faut, à
last
mon
year
sens, revenir
where, in my
très
opinion,
rapidement
they have
sur,
to
ces
reverse
quotas, entre guillemets,
these
de téléconsultation,
quotas for teleconsultation, in my
pour les
opinion.
médecins généralistes, mais
For
pour
the
les,
GPs,
psychiatres,
but also
interviewer les
for
psychiatres. Les
psychiatrists,
psychiatres
interview
font,
psychiatrists.
aujourd'hui, en termes d'activité
Today,
de
in terms of their teleconsultation,
aux alentours de 50% de leur
it represents
activité.
50% of their
Aujourd'hui, on n'a plus le
activity.
droit de
Today,
téléconsulter
you're
si
no
on
longer
dépasse
to
20%.
do a
C'est quoi ce
consultation if
truc?
it goes more than
C'est-
20%.
sincèrement,
What
je
is
suis
this? It's
désolé,
rubbish.
mais, à
I'm
un
sorry,
moment
but
donné,
at one time or
à
another,
partir du moment où
if
on veut essayer de prendre en charge
we want to
l'accès
be
aux
able
soins,
to
il faut
improve access to
libérer
healthcare, we have to
ces
release
barrières. Et puis, une dernière
this capacity
notion,
and bring down these
je vais
barriers.
rajouter une
And
notion
finally,
disruptive,
I'd like
désolé,
to talk
mais,
about another disruptive element,
Guy
and
en
I
a,
apologize.
parlé à l'introduction.
Guy mentioned this in the
C'est,
introduction.
cette notion de médecin traitant.
This idea
Arrêtons
of
avec, cette histoire du médecin
family
traitant.
doctor
Il va
with
falloir sortir du
the
médecin
family
traitant
doctor. You have to
tout-puissant
talk
de ce
about, stop talking
dogme
about this
franco-français
Franco-French
où,
dogma
le
of the
dossier
all-powerful
patient est
GP, where the
accaparé par
patient
une seule
record
personne
is
avec ce
controlled by a
patient
single
qui
person
gravite autour et
with
qui essaie
a
de
patient that
tapoter
rotates
à la
around them and
porte,
tries to knock on the door and saying, am I allowed to go and see somebody else? Can I go and see a specialist? No. Let's get out of that system. We have to have a much more pluridisciplinary approach where the patient is in the center of their record. In fact, in my health space, this is exactly what we're doing. We now have a treatment team, and that's much more meaningful. It gives greater meaning to our action, and it will help to deal with the problems of medical desert and to provide healthcare to our patients. That's what we're here to do.
Oui, je suis totalement d'accord.
absolutely
Et je dis, c'est
agree.
pas qu'un problème franco-français,
And it's not
je
just a
vous assure,
Franco-French
hein.
problem.
En effet,
Let me
c'est
reassure
pareil.
you, in Italy, it's
Je vous
exactly the
laisse
same.
quelques secondes
You
pour
have a few
une
seconds
phrase
left if you'd like to say a last phrase, last sentence, just a few seconds.
Pardon?
Maria aussi avait un
Ok. Juste dire que
Just to say
la
that
santé, c'est qu'on prend le soin, et c'est pas le soin qui
health
comprend la santé.
means
Et donc, parce que la
treatment,
santé comprend le soin, le télépatient, il est
the telepatient
il est télé
is he pays his taxes and he does everything remotely. He works remotely, he pays his taxes remotely, but he eats and he travels as well. That's on the territorial dimension. Maybe that's what we haven't described here, but which needs to be looked at in greater detail. I have 20 seconds, okay?
Peut-être rebondir sur le fait
Maybe
que
just to react to
aujourd'hui,
what you were
95% des
saying,
Français ont une mutuelle.
95% of French people have a mutual insurance fund. This provides services, including teleconsultation.
Je pense qu'on touche quand même beaucoup,
So I think we are able to get in contact with a lot of different people. I'm sorry, we've run out of time.
J'ajoute juste
I'd just like to
le
add
shérif dans le Far West,
the
pour la
sheriffs in the Far West
pourquoi pas, mais
for
s'il vous plaît,
teleconsultation, but please,
laissez-nous faire, croyez en nous, ayez confiance
Please
en
believe
les
in us,
professionnels de santé.
trust
On
in
saura
us.
très bien encadrer la
we know what we're doing and we'll be able to organize teleconsultation in the right way.